everyone. My name is Matthew Holmes. I'm a third-year medical student at the University of Alabama School of Medicine. And today I'm going to be talking to Dr. Shane Lee. He's a primary care provider in Marion, Alabama at the Marion Clinic. And we're going to be talking about just rural health and kind of the struggles, benefits, and things he's learned in working his entire career in a rural primary care setting.
So anyway, in high school I was a jock. I wasn't a good student. I did enough to keep my parents off my butt, But was capable of making good grades. It was just a matter of motivation. I wasn't really sure what I would do. I actually went to Auburn to go into veterinary medicine. And once I started working for a veterinarian, I got pretty highly motivated with the medical process in general. So I went from being an average student to being a pretty good student at Auburn, and sort of exceeded everybody's expectations, including myself. I got into vet school, went to orientation. The veterinarians I worked for called me, said, "Congratulations, come back home." At the time there was a steakhouse in Birmingham called Michael's. So they took me out for a steak. After I had a steak, we got a martini and went to the back room at Michael's, and they pulled out all their books. And they had been losing their fanny. It was during the early 80s when U.S. Steel had shut down and all. The economy in Birmingham was horrible. And, they said, "Hey, Shane, you've got the talent. You got to go into medicine." And that was after I'd been accepted, to orientation and vet school. So I was like big man on campus at Auburn. And back then, you get vet school at the end of your junior year. So I wasn't even going to take senior year. So I went back, I disenrolled, switched to pre-med. And that was tough, because I had to go back, take a year of calculus, and take all these freshman courses. And I'd taken, pre-vet was a hard curriculum. I'd taken some horrible courses and did well in them. And a lot of them were, ended up just counting as electives. But, it worked okay. I remained a decent student. I got through it, and I got accepted to medical school, which was a bit of a surprise. And because my dad worked in the plant, my grandfather died in U.S. Steel. His father was a sharecropper. I mean, we're not from a family of physicians. And Dad had a high school degree. He had about a year of college. He played a little football, and he was on a football scholarship. He went to Western Tech. He was a machinist. Mom had a high school degree. So just going to college was a little different, but going on and becoming a professional was truly different. And anyway, once I got through basic sciences, started doing the rotations, I knew I would not want the lifestyle on OBGYN. I was into it, but it was like a career decision to keep me out of U.S. Steel. It was not like all my life I had dreamed of becoming a surgeon or something. It was a career option. I wanted to not be blue collar. And did surgery rotation. I was attracted to surgery, but there again, back then the general surgeons, they're all walking around with 3-day beards, smoking a Camel and drinking black coffee. They were just, been divorced 3 times, always at the hospital, just really tough lifestyle. Back then, you didn't have trauma surgeons, so the general surgeons were doing trauma rotation. They were there 24/7. So, as far as quality of life versus income, it looked like primary care was a pretty decent balance. And I always wanted land. I wanted to get out of Jefferson County. We had about 7 acres, and when my grandfather was living, we had a little garden, a pretty big garden actually, but we'd go over there and there was a radiator from a Model A leaning up against a tree. And every time I went to that garden, he would show me that radiator, and he said, "Boy, that was 40 acres of land." So what had happened in the Depression, he had sold the last 40 acres of land that my family had so that they could get a Model A and go to New York and get a job in the steel mills. And it always haunted him because he was he was a multi-generational farmer, and they basically killed that off to survive. And I think that sort of put the desire for land ownership. And I did a couple of rural electives. I really liked the lifestyle. And I didn't want to be the guy in a strip mall, family practice clinic, or I didn't want to have to quote climb the ladder of success, or having to do ads and all that crap. I just wanted to move to a small town and meet at the dock and go from there. And that's sort of what I got. When I moved here, the guy I brought the clinic from was wanting to go back to his hometown, and the hospital had closed, and they were really in desperate straits. And they had 2 colleges here at the time, and they didn't have a physician. So it was immediately successful. Land was cheap. Bought the house in our first 80 acres for $110,000. It's a nice house. So it's just sort of a lifestyle, really. I didn't, reasonable income, comfortably upper middle class, but I can walk out my back door and go deer hunting. I want to sight in my rifle and do it in my backyard. If I want to build a barn, I don't have to get a permit. Just a freedom level that you can't get in an urban or suburban environment. And plus, once you're established and people know who you are, they treat you like a god. You get treated very well by the community, as long as you do a good job.
Yeah, so that I was going to ask about the community too. We talked about it earlier with this patient I'm going to see, the preacher also come see them. I ran into the preacher the day he left something. Are there any other stories like that you just always run into the community?
Tons of stories. It's going to write a book, but then it becomes a HIPAA thing. So especially when we had the hospital. I remember one night they called me. We had this old battle axe nurse, Betty Franklin. And she was a St. Vincent's educated nurse, chain smoker, just old school RN. But she was really good when she covered the ER on not calling me if she didn't need me. Some kid came in with a snotty nose, she'd handle it. And she called me one night and said, "Hey, you need to get in here." I got in there. When I pulled up the back, there was this old dude sitting on the toolbox in the back of the truck. He had an old double-barrel shotgun, and this is all true. A bottle of whiskey, sitting there mumbling. I go in, and it's the dude's son. They'd gotten an argument over some crack. He had shot this guy at about 3-foot range with a shotgun. There was a glancing shot that took off the left side of his chest wall. The dude's conscious. I walk in, his chest wall's laying over on the side of the gurney. You can see his heart beating and his lungs, somewhat expanding. And he's just got this appropriately shocked look on his face. And oh my God, what did I do? And back then they just passed the COBRA laws. So regional hospitals interpreted that to their advantage. They interpreted it as like I had to talk directly to a trauma surgeon, and the trauma surgeon tell the ER doctor that he would take the patient before I could route the patient. And I couldn't get a trauma surgeon on the phone, which was typical. You could never get a trauma surgeon on the phone. You could never get a neurosurgeon on the phone. And if you did, they'd have this smart-ass attitude like, "Well, hey, why don't you send me a good patient during the day and I'll take your crap at night." That's a quote from some guy that was up at Caraway Hospital one night. I had a closed head injury. And we didn't have a ventilator. I had to intubate him, and I bagged him for like 4 hours trying to get a neurosurgeon to take him. But anyway, I got back from Desert Storm, so I had some trauma. I'd taken ATLS, so we folded the dude's chest wall back up and went into the old surgical supply room, found some old surgical wire. We wired his chest wall back up, took a bunch of Vaseline gauze and sort of sealed it up. Everything I did, he got better, which amazed me because I figured he's fixing to die in a minute. Put a chest tube in him. He starts ventilating a little better. Intubate him. Betty's bagging him. and I'm not having to leave him to go find crap. Put a catheter into his pericardium and leave a syringe with a stopcock on it. I'm pulling off the blood out of the hemopericardium, is that the term? So he gets chest tube, he gets pericardial catheter intubated. I think they had to do like they couldn't get an IV. I think they did like a venous cut down or something. Oh, I know what I did. They just came out with interosseous stuff. We did it in Desert Storm. Get an IV and the, I can't think of the term. What's the term? When you put the needle in the bone marrow.
I don't know. I've heard of my EMT friends talk about it.
Old timers disease. But anyway, that's what I did. I found now you got kits for it, but back then we would use the needle that you would use for spinal tap and just sort of pivoted into the bone marrow. So we got an IV. That guy made it. And then, I left Betty bagging him, and I started calling. Nobody would take him. He was uninsured and all this crap. Couldn't get the police out there. The whole time the old dude's out there with a shotgun babbling to himself. And finally I called one of the old general surgeons in Selma that I studied under as a resident. He wouldn't take him at first. And I was about in tears. I said, "Come on, Bob, take this guy." So he took him. He ended up dying. He died about 2 weeks later at Ards, but he made it out of Perry County. The next day, I had to drive to Birmingham. I was doing my sports medicine fellowship at Health South with Lee McAndrews, and they'd set me up this hybrid arrangement to take it since I was working. I'd drive up there like 2 days a week, scrub in, and maybe an afternoon a week. And so I'm sitting around the doctor's lounge. They were, "How'd your night go?" And I told them. They went, "Damn, you really did all that?" I said, "Yeah. That's pretty impressive." He goes, "Hey, we're going down to the injury clinic at Auburn this afternoon. You want to go?" I think I'd die on the road if I tried to drive. No. Meet us at the airport. And they had their own plane, So I flew. It was all like a dream because I was doing it on like 2 hours of sleep. And so I meet them out there. Get on the plane, get a cup of coffee, some sort of little dessert. We fly down to Auburn. Tuberville meets us on the tarmac with his crew. We get in the van, drive over, and there were several celebrity players. I was meeting all these celebrity players. I said, "Man, I can't believe I'm doing this." I'm like examining their ankles, get back on the plane and fly back. And of course, then I got to drive back home and take call that night. But it was a bizarre 36 hours. So that day always sticks in my head.
So what does a day-to-day look like for you?
Well, a lot different now. There's no hospital. The nursing homes basically are our hospitals now. So we've got, between the three facilities, we've got about 300 patients in the nursing homes. And I've got partners now, my son, my daughter-in-law, and then Karen, nurse practitioner, partner. And we were one of the first people in Alabama to get, I was one of the first physicians to get a nurse practitioner partner. We've had them since the early 90s, just really out of necessity. But now I'm fine with them. Treat them like my equal, and most of the time they are my equal, and sometimes my superior. But so one of us, of the four, will rotate in the nursing home every day. Two of us run clinic, and one of us will do what we just call RX, which is basically you're on the computer, you're addressing abnormal labs, you're filling refill prescriptions requests, you're seeing work-ins, and you're stomping out fires. So, they call and somebody wants to make a home visit, or one of the nursing home calls, and the nursing home of the day doc is at a different facility, and run over there. So, two in the clinic, one in the nursing home, one floating. We do take call by telephone. Occasionally, I'll get up and go to the nursing home, or I'll go make a home visit off a telephone call. Most of the time you handle it over the phone. So, I mean, it's demanding in a much different way. And the worst part of now is the amount of time I have to spend in front of a computer versus in front of the patient. It's probably crossed the 50% line. You know, it's at the end of the day, and I used to see 60. I mean, we would crank them out. And it wasn't because we were trying to make a ton of money. It was just out of necessity. Now, 20, I mean, you know, the wheels come off at 20. You'll be here at 8 o'clock at night doing chart work. And you really, in primary care, it's hard to template because every patient's different. Like if you're a cardiologist, there's some redundancy, you know. So you can do templates and you drop and drag that stuff, or you're making enough coin to where you can hire a scribe. And you just don't have that much revenue flow in primary care. You can't afford a scribe, so you're doing all your chart work. And it's all consuming. And that's probably what's going to drive me to retire, is just reach a point where I don't want to deal with it.
So what else has changed, like, the past 20, 30 years about your abilities? Like, I know when they showed me around the clinic, they said, oh, yeah, I used to do scopes here.
Yeah, I mean, we used to do colonoscopies and EGDs and had a treadmill. We did those. And that was sort of I sold my practice to the hospital in Selma like in 98. I'd had it. I was Shane Lee Inc. for about 9 years. And depending on the hospital corporation that owned the hospital, it was either a good thing, neutral, or bad. And I forget which corporation got it, but one of them was profoundly risk averse. And you know, I was going along doing my scopes for conscious sedation, and they said, all right, well, you got to get your nurse practitioner signed off, and she's got to sit in there with the patient, you know. And it really cut in on the profitability of the procedure, but I still wanted to do them because, one, I like doing them, and two, I was doing them on a lot of people that weren't going to get it done otherwise. They just didn't have the resources to make 2 trips to Tuscaloosa to see it. You know, you got to go and have the office appointment, then you got to go back to get the colonoscopy, and you got to have a driver. And I mean, for my folks, my people, that's like a moonshot, you know. So we were scoping people that weren't going to get scoped otherwise, and that's why I hung on to it, really. And then my scope broke, and it was an old Olympus scope with actual lens on it. Hey, good morning. As opposed to a video thing. Well, it broke the colonoscopy, and they were going to fix it, and they were going to give me a hand-me-down scope from the hospital. And then one night, literally, they came up and got all the scopes. And I go in, hey, where's my scope? I said, well, we've got a new risk management thing, and they don't want you doing conscious sedation remote site, so we've credentialed you to do scopes in Selma at our new outpatient surgical clinic. Which it had nothing to do about risk mitigation at this point. They just, if their general surgeon did it in their outpatient surgical center, their profitability went up about 200% versus me doing it in my clinic. That was the bottom line. It had nothing to do with risk. It had everything to do with they had a new general surgeon that needed referrals, and they could make more money with him doing it than me. And I haven't forgiven them. I mean, if you go back, one thing professionally that's pissed me off for the duration of my career, it's been that. Because there was no sense in doing that. And you've denied people in need basic screening services when you made that decision. And the treadmill that broke down, they never repaired it. Same sort of deal. You know, got a cardiologist. They make more money having the cardiologist do a treadmill than me. But we still do a reasonable amount of procedures. And I mean, that's something I've noticed teaching with the residency programs is they really, when I went through residency, it was very procedure oriented. We did flex SIGs in the residency clinic. We did direct nasolaryngoscopes. scopes. We did treadmills. It was a procedure oriented education. And then the general surgeons were desperate for somebody to first assist. And when we did general surgery rotation, we scrubbed in constantly. We were across the table from the surgeon. Same with orthopedists. So it was a real hands-on experience, and you became procedurally competent. And they're just not teaching it. They just don't teach it. I mean, I've had fourth-year medical students. I say, well, you know how to throw a stitch? Yeah. And then they'll pick up like the hemostats instead of the needle holders. Or they'll like be trying to cut a mole and they'll have the scalpel backwards. It's obvious they don't have any. Hey.
Hi.
So, and the Academy of Family Medicine, their holy grail is OBGYN. They won't give it up, but they've given everything else up. And, maybe it's reasonable if you live in rural Nebraska to be a family physician / obstetrician, but even in rural Alabama, that's not reasonable. You need to be either. And I did it. I had 120-something deliveries as Shane Lee Inc. But there's just not enough you for that. You can do family medicine, you can do OB. It's damn hard to do family medicine and OB. So I don't really understand why, from a lobbying standpoint, the AAFP is focused on family obstetrics so much at the cost of giving up something that would really be applicable, like endoscopy training or doing the basic trail. I'm not talking about a stress echo. I'm just talking, the 40-year-old guy walks in and has atypical chest pain, and you pop him on the treadmill just to make sure he's okay. That was so convenient. And now all that's gone. And it ain't coming back.
So, has it gotten worse with patients not being able to go see specialty clinics in other cities, or has it gotten a little bit better with technology, or how's that changed?
Well, for my patient population, the challenge is, all right, so say they need a colonoscopy. The nearest place they can get one's Selma. That's 20 from Marion, which is the population center of this county. It's about 25 miles. So that means you have to have a car and a license and gas, and you have to have the intellectual capability. I'm not saying people are stupid, but older people, sometimes they get lost. To get to Selma for an appointment, and then you 1, 2, 3 weeks later, after you do a home prep kit that you may or may not have picked up at the pharmacist, you have to have somebody drive you down there, usually at 5 o'clock in the morning, get your colonoscopy, have them drive you home, and then if they pull polyps, you got to go back to go over the pathology report, which never happens. So, it's a challenge. It's a challenge in a rural area. You just don't have transportation. Some of my patients, you tell them you got to go to Selma, you might as well tell them they're going to Mars.
And Selma's 35 minutes away max.
Yeah. Because they just don't have the resources. Either they're young and financially strapped, or they're elderly and they just physically can't get in the car and drive to Selma anymore. And the problem is there's talk about opening a rural access hospital here, but that's just a pipe dream because we can't get enough people to fully man an ambulance service. How are you going to man a hospital 24/7? And have X-ray tech and lab tech and kitchen staff and security and all that, and still, that's not going to solve your procedural problems. Because the pattern I've seen with some specialists, they'll move to Selma, they're starting out, and that whole back wing of my office was built to have subspecialty clinics. That's why it's there. And they'll go, hey, we'd love to start coming up here to clinic. And they do, and it's successful, but then their Selma operation gets successful. So they say, well, I really don't have the time to come up here anymore. 100% of the time, that's the way it goes. And that would be the way it goes, having some subspecialists come down here and do procedures. It'd be a hit or miss, you know. Once they got established, they quit doing it. And it's just the way it is. Subspecialists will deny, sorry, I've been here 35 years. That's the way it is. It's the way it is in Marion. It's the way it is in Demopolis. It's even the way it is in Selma for subspecialists coming to Selma. They'll do it for a while, and then once they get established or get tired, they'll quit doing it. So that's why having some of the basic procedural skills is really important in primary care. The only reason I still give AAFP money is so I can get my CMEs done. That's the only reason. The quality of the magazine's gone down, and they rolled over under the Obama administration on several things that just made the practice of family medicine really challenging. One of them being this. The advent of electronic medical records for primary care was a death knell. And AAFP didn't, and they embraced it. They embraced it, and I guarantee you interview 30 family physicians that have been practicing for more than a year and are actually practicing. I'm not talking about academics. They're actually out in the field practicing. And you ask them what's the worst thing about family medicine, they'll tell you it's electronic medical records and the negative impact it's had on their time to be able to practice medicine.
So let's wrap it up with, what do you think the outlook looks like for rural medicine in Alabama? And then any advice to students or residents that want to do it?
Yeah, I mean, I advise them to do it. It's a hard road to hoe, and you're not going to get rich. But quality of life can be really good. It can be really good, and I have a good life. Last night, my wife and I canned beans that we've picked in our garden, which is right across from my house. And, we have a garden, we have a fish pond, we hunt together, we have fruit trees. My grandkids are a mile down the road, and they get to come down, and they get to run around and climb trees, and rural living is quality living versus suburban or urban living. It's the quality. Family medicine in a rural environment allows you to live well above your means if you were a family physician in an urban environment. I can live quite well down here on family medicine income because the cost of living is cheaper. And you don't have to travel 3 hours to go to the hunting club, or you don't have to be in a fishing club, or if you're into natural stuff, you want to hike, you want to canoe, it's all out your back door. And you're sort of the king of your own kingdom. You don't have all the silly regulations that go along with living in a planned community. Like I said earlier, if you want to build a barn, you build a barn. If you want to sight in your deer rifle in the backyard, go do it. If you want to have a dog, you don't have to have him fenced in. He just runs around in the yard. And we have cattle. That's another thing. By having a farm, that's an excellent side hustle to sort of help you from a tax management standpoint. Because, you're in primary care, you're going to be at the top end of that tax range where you're really going to get slammed. So, you're going to be making between $250 and $350. And that's, you look at the tax brackets, that's where you really get it. So you got to get a side hustle. Ours is the farm, plus the 1099 money I get from being a nursing home director and hospice director. And you get all sorts of other little things you can do. We got a college in town. I can teach there. I'm teaching at the residency program in Selma. So you can live quite well with a modest income.
I think we can wrap it up there. Thank you.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.